You are preferred to organize. Probably I will ask you to organize my summer vacation for this summer.
It's already done.
Thank you so much. And now I'm Eduardo Savarino, University of Padua. I'm co-chair this session with John Diffham, who will present himself probably.
Yeah, Professor Zerdi from USC in Los Angeles, and it's my honor to introduce one of my previous fellows, which makes me feel even older, Sumeet Mittal, who's Professor of Surgery at Creighton and currently working in Phoenix.
Thanks. I was just 1 year. He was a first-year faculty, so he's not that much older. I'm really old now. So yeah, thank you again, Mark, and it's really a privilege to be here. Ascona is like the Davos of the esophageal world, I guess. So I'm just going to get started, and these are, what is the next step? Yes, here. So these are my disclosures. My salary is from Dignity Health. It's completely work hour view based, so there cannot be any conflict with the talk. I'm a consultant for a few companies, but there is no conflict with the current presentation. The real disclosure is I make a living out of others' heartburn, or actually more specifically with their incompetent esophago-gastric junction. So it is a conflict in my mind on that way. So the parts of my talk are going to be to talk about the current knowledge of the EGJ metrics as to what I see. Some of them have been accepted, some have not been. The current definition of the disease, and the second part, which I hope I get to, would be to make a plea for diagnosing the disease maybe a little earlier than we do right now, and maybe what, in my opinion at least, are the new frontiers. So I'm going to probably leave you with more questions than try to answer them by the end of this talk. First, to start off with terminology, EGJ, I go back and forth, between the LES complex or just simply calling it the LES, but it includes both the intrinsic lower esophageal sphincter and the extrinsic, which is the CD, which is the diaphragmatic crura, and the RIP and the PIP, the respiratory inversion point and the pressure inversion point, are pretty much indicating when the transition happened from the abdominal cavity to the thoracic cavity, and I may use it intermittently, differently, because going from one school of thought to what it's used right now. And this is a diagrammatic representation, what the crural diaphragms do. The second terminology is going to be the disease, because that's a topic, EGJ in health and disease. So the disease at present is defined by symptoms, some mucosal changes, grade B or higher, and distal esophageal acid exposure. So I'm just going to have some thoughts on that, though the distal esophageal acid exposure is probably the most standardized and the gold standard. The EGJ has two aspects. One is the compliance, which is to allow the antegrade flow. We have talked ad nauseum about it yesterday. So today's talk is to talk about the competence as to prevent the retrograde flow, or the barrier to gastric contents refluxing back, while allowing, in the normal situation, some gaseous venting. So that's what I'm going to talk about. First of all, I'll just say that all the data, or at least the discussions that I talk about, that what has shown that this is a competent EGJ versus an incompetent EGJ, is based on the pH testing, not just whims and fancies. And the pH testing, in more part, the gold standard, in my opinion, still is the catheter-based pH, which was placed 5 centimeters above the upper border of the intrinsic LES, where the pH of less than 4 was counted as a reflux episode. The meal periods were excluded, the patient position was important, and the Demiso score of less than 14.7 was normal, which was roughly an acid exposure time of about 4.2%. However, at some of the data is based on the Bravo, which is a pretty good surrogate, and that data gets mingled with it, but it is still distal esophageal acid exposure. And this is a 3D representation of what the hiatus and the GE junction looks like. But to understand it, it's a simple 2D diagram that basically there is a thoracic cavity where there is normal intrathoracic respiratory variations, the abdominal cavity, which has the opposite respiratory variations. The GE junction, or the EGJ, or the LES, is kept inside the majority of the time below the hiatus, below the PIP, and somewhere this dotted line there is this squamo-columnar junction, and we exactly don't know where it is, but we have some thoughts as to where it is. But if you look at manometrically, I would like, actually, especially the young guys who haven't read this paper, probably more than 30, 40 years ago now, which had a pull-through manometry from the abdomen coming from the, left side. This was in the abdomen, and you're slowly pulling it out. it leaves the gastric baseline, indicating that it's entered a high pressure zone or the sphincter. At some point, there is a respiratory inversion point, which I said is now we may call the PIP, the pressure inversion point. And by convention, the group said that that's where we should measure the lower esophageal sphincter pressure. And then as you come up, it goes below the gastric baseline, it leaves. So there is a pressure here, there is an abdominal length below this, and there is an overall length. And 3 criteria were described as to when a valve is incompetent and correlated with the distal esophageal acid exposure. Now, this is what we see. So it is actually distal to proximal, and this is temporal. So if you just look at one point, you have this gastric baseline, it rises up, which is in the normal situation, both the lower esophageal sphincter and the diaphragmatic crura. At some point, it transitions into the abdominal cavity, into the thoracic cavity, and then goes below the gastric baseline, indicating that it's above the sphincter. So this is what the pull-through manometry picture would look like. If we took at any one point, it goes upwards rather than across, because that was pull-through. So back in 2007, this was the first time with the manometry. And other disclosure was that when I mentioned John, it means John Pandolfino and not John Lipham. So John's group put out the classification of the EGJ classification, type 1, type 2. Type 1 was normal, there was no separation. Type 2, the separation was 1 to 2 centimeters, and type 3, anything that's more than 2 centimeters, but subdivided whether the RIP or the PIP is below the LES, meaning it's in between the cruise and the LES, or it is above the LES, indicating that the sphincter is still in the physiological abdominal cavity. And so back in about 2012, one of our fellows did a lot of work and looked at the other parameter and proposed what we basically did. We took the DCI tool and dragged it for 10 seconds across the EGJ, or the lower esophageal sphincter as we called it, and came up with this new parameter called LESPI. And an LESPI of less than 400 in people without a hiatal hernia was associated with reflux and the abdominal length, which was similar to what Dr. Demiso's paper had said. But actually, it was completely ignored by the GI community at large, except by John's group, who refined it and made it into the EGJCI. They used the same tool, dragged it across 3 respiratory cycles, which is generally more than 10 seconds in most people breathing at calm, formatted to a 2 millimeter isobaric contour, and basically then divided with the time frame to give it per second. So, and the number they came up with was about 39. So it was 39 per second as compared to 400 every 10 seconds. So pretty much similar. And what we did, we went back and looked at the EGJCI in about 50 patients and found that pretty much exactly they're the same number, just one is over 1 second and one is over 10 seconds. But obviously, probably none of you has heard about the LESPI. And now I know how mind worker feels in the fields of Sudan. But, so that's what it is. So the next part is that what about the configuration of the LES and the CD and the separation? So again, one of our fellows looked at it, Dr. Akimoto, in that these are the patients who have type 3 hiatal hernia, so more than 2 centimeters, and we tried to separate the distance by about 5 millimeters each time. And the proportion of patients who had abnormal distal esophageal acid exposure progressively increased to the extent that if you have a more than 3 centimeter separation of the LES and CD on manometry, uniformly you have abnormal distal esophageal acid exposure. Now, these are the people who are being evaluated for reflux, not for the giant intrathoracic stomach. So if you have a more than 3 centimeter hiatal hernia manometrically, it's pretty much incompetent as measured by distal esophageal acid exposure. Then the second thing we looked at is that the Chicago classification about the CD and LES and CD separation and the pH. We looked at about 49 patients with a type 2 LES, meaning 1 to 2 centimeter hiatal hernia, and about maybe 64 patients with type 3. And this is type 3A, where the PIP is below the LES, and type 3, where the PIP is above the LES. And these were the numbers. And basically, when the RIP is above the LES or the PIP is above the LES, indicating that the sphincter is in the abdominal cavity, the distal esophageal acid exposure was related to the size of the hernia, about 30% with smaller hernias and about 44% with larger hernias. On the other side, when the RIP, even in this group, was below the LES, it was a smaller number of people, and with larger hernias, the degree of distal esophageal positivity was much higher, 56% for 1 to 2 centimeter hiatal hernia, and almost 78% if the hernia was more than 2 centimeters. So we propose an alternate classification, which is type A, B, and C. Basically, the type A is same as type 1, which is that there is no separation. But once there is a separation of more than 1 centimeter, we feel it is important that where the location of the PIP or the RIP is. So if the PIP or the RIP is above the LES, then you're less likely to have reflux as compared to if you have the PIP in between the LES and the CD, indicating that the lower esophageal sphincter is in the chest and not in the abdominal cavity. And this is what we found, that it was surprising that even if you had a hernia, the number of reflux, proportion of patients with abdominal reflux was similar to type A as compared to just jumping up once your sphincter is in the chest. The next thing is the Amsterdam group actually showed that we do a manometry, for 10 minutes, but the patient may not have a hernia. So they did prolonged manometry and noted that at times the patient develops a hiatal hernia after a meal period, and those are associated with reflux events. And that was an intermittent hiatal hernia, and this is obviously clearly cannot be detected based on stationary manometry. So again, having nothing better to do, we had some fellows looked at this phenomena, what happens to the sphincter with swallows. So we noticed that in every patient, the sphincter rises a little bit. We know that because of the contraction of the longitudinal muscles, but then it comes right back down within 1 or 2 respiratory cycles. However, there was always a subgroup of people in which we found that the sphincter did not come back within 1 to 2 respiratory cycles, and what we called it was a transient hiatal hernia. And we called it, yes, you don't have a baseline hernia, so it's type A or type 1, but then we subdivided it that you do not have a transient hernia, and you have a transient hernia, which was defined either as more than 2 centimeter separation beyond 2 respiratory cycles, or more than 1 centimeter that was just beyond that on multiple swallows. But again, we found that these patients have much lesser incidence of abdominal distal esophageal acid exposure. I don't know what the percentage was, I put it there, but as compared to these people. So I think on station manometry, we probably can pick up some of those patients the Amsterdam group described who were getting an intermittent hiatal hernia, indicating that the sphincter is dynamically getting incompetent at times. What are the other metrics that we have available and we may be able to use? We spoke about, there is intragastric pressure, so more pressure in the abdomen, the more likely you're going to have reflux. The decreased thoracic pressure, that doesn't get a lot of attention, but I work with a pulmonary group, and the patients with restrictive lung disease have very, very low intrathoracic pressure, and almost it's sucking up reflux across the sphincter. And then came the thoraco-abdominal pressure gradient, that what is the pressure gradient from 5 centimeters above the sphincter to 2 centimeters below the sphincter, and you can calculate a trans-abdominal pressure gradient, which was first described by Dr. Demuse's group, and then we made an adjustment. So basically the concept is that the reflux is a net result of downward forces pushing things up and upward forces that are sucking things in, counterbalanced by the lower esophageal sphincter. Do not blame the sphincter on this guy's reflux. So Dr. Demuse's group basically gave that number, thoraco-abdominal pressure gradient, the intrathoracic, so the net positive push, the abdominal pressure minus the thoracic pressure. So this is the net push of reflux, and then we adjusted it based on by subtracting the pressure of the sphincter. So that is the barrier. If your forces are more than the lower esophageal sphincter pressure, then you're more likely to have reflux. It's logical. And we found that they have more reflux. So what do we know about the barrier competency in all is that the EGJCI, which I still insist on calling LESPI, and the LES-CD separation of more than 3 centimeters are associated and shown to have with abnormal distal esophageal exposure, and they have become part of the Chicago 4.0. Finally, we do have in the EGJ metrics. These are in this situation because the EGJ classification in Chicago 4.0 mentions that in patients with less than 3 centimeter hiatal hernia, probably the location of the PIP or the RIP is important, but doesn't commit on either side, and that we should think about the obesity or the abdominal pressure. So those things have made to the Chicago 4.0, and I'm hoping Rena would someday include the transient hiatal hernias and maybe 6.0 or 7.0 or whenever it's blessed by John. And the effect of thoracic pressure, what the variations are, I think sometime we may be looking at that in future. So we came up with this composite EGJ score, basically based on the type of morphology, the LESP or the EGJ-CI, and the thoracoabdominal pressure gradient adjusted for the LES. And we came up with a score from 0 to 6, and you can see that it pretty well correlated with the degree of distal esophageal acid exposure, depending on how bad your sphincter is, but it has not yet been blessed. So these are the various ways now that we can have that the competent can fail, that they could be a weak and intrinsic lower esophageal sphincter is weak. The aperture of the hiatus is bigger, so it's not holding it tight enough, or there is actually a hiatal hernia. But one may say that, how does it matter? Why should we care what is the mechanism of failure? Because a failed valve is a failed valve. But I think that probably was true in 2000 because we had only two options. Either we could cover the problem with a PPI or take a big hammer, which was a nascent fundoplication. But I don't think that's the case anymore. We have a lot more options, both on the medical side for better medications, neuromuscular modulators, and we have less invasive or less drastic options, such as endoscopic treatments. And even if they're laparoscopic, there are a lot of other alternatives. And even if you go with the fundoplication, you have a lot of different fundoplications that we do, which probably have a different risk profile. So I think in 2023, it may be beneficial that we can classify the valve and direct the treatment based on that. So this is my flight of fantasy, is that we can identify the exact type of failure, what type it is, based on the configuration and the pressure. We assess the effect of the pressure gradient and then choose the right tool, whether it's medicines, whether it's endoscopic treatment, whether it is laparoscopic repair with some kind of augmentation, whether it's magnetic, electrical, or the new reflux stop, or it's a type of fundoplication. And I think we already have the tools, and it really should not be a flight of fantasy. So this is the first part of my talk, and I'm just going to talk is that the actual anatomy that I made in 2D is not real. It just doesn't show. Maybe it'll show now. Actually, in the 3D, the hiatus is not in 90-degree parallel to the G junction. This is how it looks surgically to us. So what can we do that to understand better? 3D manometry was used first by Peter in 2008, that's Peter Kahrilas, and then by placing a clip, Ravi Mittal basically showed that this is the left side and oriented it properly. This is the left, or the orientation on the left as we look surgically, and this is the right, that it is asymmetrical and that you change with inspiration and expiration. However, this is not really a new concept. This was first described almost 30 years ago with the vector volumes, which pretty much have lost favor, but you get a very good idea that there is the sphincter is not symmetrical, just like the 3D manometry shows. This was shown much earlier, and that the volume of this diamond is probably related to the competence, and that is probably what we are measuring with EGJ, CI at one level, and so forth. But let's look into the future. Like I said, I will leave you with more questions than answers. So my plea would be that we need to diagnose disease earlier. I think the pH, distal esophageal acid exposure of 4.2 or 6% is much, much later in the disease than we need to be before we do something about it. And then what are my next thoughts on what way we need to go for the EGJ metrics beyond the 3D? So at present, the gold standard is the distal esophageal pH monitoring. Everybody would say that the person on the right with a pH score of 108 and the acid exposure time of 29% is pretty bad. This person has acid exposure of 5.7. If he didn't have much symptoms, according to Leon, he would not be counted as reflux. If he had symptoms, he would have been counted according to Leon classification. And this is a person who has absolutely no reflux episodes during a 24-hour period. This is the pretty much 100% Leon classification cutoff of 6%. Yes, you have bad reflux. Probably 4% if you use the Demeester score or have symptoms according to Leon. But why shouldn't the distal esophageal cutoff or threshold of defining a disease be much lower? Again, open to question. Then we do a pH of less than 4. What about a pH of 4.1 or 5? Is that not because of distal esophageal acid exposure? The pH of 4 was used because that is what was felt, that pepsin is activated, and that's when you feel the symptoms. But we know that a pH of 5 is also a reflux event. Should we use that in our criteria? What about looking at closer to the esophago-gastric junction rather than 5 centimeters above? Is there more distal esophageal acid exposure? Maybe we have technology now that we didn't have earlier. What about alkaline reflux? Maybe we need to look at proximal reflux episodes to decide. Again, these are all thoughts we need to start defining the disease in a different fashion, maybe earlier in the disease and differently. At present, grade B, grade C, grade D, B, C is severe esophagitis, pathological reflux. You don't need to do a pH testing. But what about anywhere from normal to grade A? Grade A esophagitis is also because of distal esophageal acid exposure. We just don't consider it pathological right now. What about earlier things, erythema, hypervascularity, the tight junctions on biopsy, and so forth? This is our threshold of disease now. Why don't we have it somewhere earlier? Again, just thoughts, more questions. Esophageal cancer because of reflux. Everybody knows that was because of reflux. Long segment Barrett's is because of reflux, diagnosed as. What about short segment Barrett's? It was not even recognized as a disease till 25 years ago, but now we know it's a disease, but still it is not that, yes, the person has pathological reflux. What about even a small tongue of Barrett's? What about the small irregular squamous junction? Right now, this is a threshold of severe disease. Maybe it should be here because these events are also because of distal esophageal acid exposure. Then looking at, we have better microscope or endoscope to look at. This would not be called reflux or pathological reflux in most cases, but you can see it. What about a shorter tongue? If you look on retroflex, on antegrade view, you would have seen absolutely no changes of suspected changes of the squamous mucosa. And if you have even a better endoscope or a scope, which is a microscope, you could see that if the squamous junction, if by some magic our endoscope could say that the squamous junction changes to the oxyntic mucosa, but there is a gap, is that normal or abnormal? Again, I'll leave it to open. Right now, this is the threshold of severe disease. Why shouldn't it be here that there is an the squamo-oxyntic gap? Again, a lot of controversy, but again, to think that why do we have this so-called cardiac mucosa? So like I said, I'll leave you with more questions. So what, in my opinion, are the next frontier for the esophago-gastric junction? I have a question. Does anybody know where the sphincter is when we do an endoscopy and surgery? 100% of our treatments are directed at reinforcing the sphincter, whether it's endoscopic or surgical, but we have no idea where the sphincter is actually. At times, squamous junction can move up and down, depending on Barrett's esophagus or changes that precursor to the Barrett's. So, and why is that important? It is, I think, important so that hopefully it will help us position. I refuse to buy that the links, all the swallowing problems we are having is because of the scarring and fibrosis. We were discussing, John and I, that sometimes we go in for dysphagia after links and there is not much scar tissue there. Maybe it is because where we are positioning it on the sphincter. Maybe we can do endoscopic treatments if we can identify exactly where we should be able to put it on the length of the sphincter, which is normally between 3 to 4. So maybe that is where we need to go next, is that we need to identify where endoscopically or surgically the sphincter is, do some work that where should we put our anti-reflux mechanism, whether it's endoscopic or surgical, doesn't matter, and maybe we'll have less side effects of the treatment. So in conclusion, I would say that the barrier exists. It can be measured, but we are probably very primitive right now. There is various level of incompetence that we can describe even now. We probably can direct treatment based on that, but I think we're still pretty barbaric about it. We need to define the disease earlier and in a better way and alternate ways. We need to learn a lot more, and the only way would be we need to ask different questions or ask the questions differently. And maybe 10 years from now, we will, based on asking these questions, have completely new options which are much better for earlier disease and prevent and going forward. So this is my thought on the EGJ. I expected silence, so great. Thank you. Thanks a lot.
I think we have time for a couple questions. Anybody? While they're thinking, Sumeet, you talked about the lower esophageal sphincter a lot.
Yeah.
What contribution to the barrier do you think that provides compared to the crural diaphragm?
I think by the time we are defining the disease with the high threshold of 14.7 pH score or the 6% acid exposure time, the diaphragm has failed. I think we are not even picking the disease earlier. Probably if we defined with a much lower threshold, it probably contributes. So again, where do you define disease? Coronary artery disease. You say it's coronary artery disease when it's more than 70, it's 50% occluded. Well, is 5% occluded or non-calcified plaque not coronary artery disease? So again, it's in the threshold. So when the disease is so bad, I think the crural diaphragm has failed and needs to be fixed. And a bigger component of it overall. But I think in earlier disease, there will be cases in which the hiatus is not destroyed yet, or it's a different phenomena that is not happening and the sphincter is weak and you can just do endoscopic treatment. I think that's the reason all the endoscopic treatments are very poor outcomes, is because we have defined the disease too high. That's my opinion. Those are the thoughts. That's why we need to fix the crura when we do a CTIF, right? It's pretty good looking fundoplication, so.
Johannes Lenglinger from Bern. Do you have an explanation why patients with type 3B hernias have less reflux than 3A? I was somewhat surprised by that. Because
well, I just think that, it's a PIP or the RIP. So the RIP means that that is the point where your organs went from the abdominal cavity, the pressure, to the lower thoracic cavity. If your LES, which is 3B, is below the PIP, I think maybe the abdominal pressure is reinforcing the sphincter, as compared to in 3A, when it is above the PIP, it is in the thoracic cavity and it's not getting reinforced by the abdominal forces. That is the only explanation that I have, and me and Peter talked a lot about it at the EGJ, and whether that's real or not, I don't know, but that's what we found. So.
Yeah, I think the alternative explanation is that you have competence of the crural diaphragm in one circumstance where the PIP is low, and you have incompetence of it when it's up at the sphincter. Now, why you get that transition up there, I can't really explain, but it has to happen at some point.
Yeah, it's probably because of the phrenoesophageal ligaments attached on the top of the sphincter, and they are contributing. So, the crural diaphragm pressing on the sphincter or making it more competent in a lesser hiatal hernia where it hasn't gone up. But if the sphincter has gone really high up, and then it really doesn't do that. So again, we need to understand that, but that's an observation. Well, but again, 1 to 2 centimeter hernia, we're talking about trapping of contents. That just doesn't make sense. Maybe I don't know. Could be. I don't know.
And how do you assess the PIP? Do you assess it during quiet respiration or
quiet
during
respiration.
Deep quiet respiration?
Quiet respiration.
Because there are some instances where you have type 3B during quiet respiration, and if you do a deep breathe, it becomes 3A.
We have, at least thank you for giving the suggestion. That's what I'll have the fellow do next, but I have not paid attention to that, but that's a very good observation. I think probably those people have more reflux. Why shouldn't there be 3A1, 3A2? I don't know. Again, we have to ask these questions a little better. That's what I think.
Rami Swais, London. You mentioned that you measure the intra-abdominal pressure gradient. How do you do that, and how do you use that in your therapeutic algorithm? Do you
Well, we don't.
Weight or what?
We don't use it in therapeutic algorithm because we don't know yet, except for telling a person how to lose some weight, you know. But we calculate it by dividing the gastric pressure at a point of inspiration 2 centimeters below the LES-CD complex, and then you have the intrathoracic pressure, which is 5 centimeters above the upper border, and you subtract and come up with a number. And then you can adjust it for the LESP, which is in the lower part of the abdomen. Again, this is something that we have noted. We cannot at present factor it into our algorithm, but probably if you don't have a hernia, but you have a big thoracoabdominal pressure gradient, maybe a lesser, maybe, again, I don't know, that an endoscopic treatment that reinforces the sphincter only a little bit would not be enough, and we need to do something more stronger. I don't know. I don't have the answer to that, but we have the capacity to be able to look at it and see that if it makes a difference. I don't know the answer to that yet.
Thank you. I believe we should move on. Thank you, Sumeet.
Thanks a lot.
The next speaker is Roberto Penagini from University of Milan, and he will talk us about provocative testing maneuver in GERD, rumination, and related disorder. Please, Roberto.
Yes. Hello, everyone. Thank you, Mark, and all the scientific committee for inviting me to this quite important meeting to talk about this difficult subject. Now, these are my declarations, and the content of my talk is not influenced by any. Now, the rationale of the provocative testing and maneuvers in GERD is, one, to rule out obstructive esophageal disorders, both in differential diagnosis and also after anti-reflux surgery. And then these may help to optimize treatment and may help to avoid reflux testing. And these last two are quite some important rationale. And let's see at what stage are we now. I'm not going to talk about ruling out obstructive esophageal disorders because of time constraints, and these are the provocative testing that are useful. First, I'm going to concentrate on the role of contraction reserve, and you can see here the various testing that can assess it. First of all, multiple rapid swallows. We all know that during rapid swallowing, the strength of the peristaltic wave generally is higher, and it is so in about 80% of healthy subjects and about 60-65% of patients with reflux disease, both in effective motility and normal motility. And what it is important is that the presence of the contraction reserve is associated with a lower acid exposure time in GERD. We also know that there is a minimum number of MRS, which allows us to evaluate contraction reserve with a good accuracy, which is 3 compared to the gold standard of 10 MRS. And then let's start with the evidence of possible usefulness. This is an important paper of the group of Prakash 10 years ago, which suggests the usefulness of MRS in predicting late dysphagia following anti-reflux surgery. And you can see that those patients who had late dysphagia, a very low percentage had a contraction reserve compared to all the others, those with no dysphagia, with early dysphagia, and the normals. And he found a DCI ratio threshold segregating patients with a certain sensitivity and specificity. And later, the same group, in another study of 153 patients, found that at multivariate analysis, absence of contraction reserve remained the only variable which were able to predict clinically significant late post-ARAS dysphagia. After that, I just found a paper looking at the same subject after magnetic sphincter augmentation and showing that, in fact, absence of the contraction reserve predicted dysphagia. But you can see there is quite a wide variability in those who didn't have dysphagia. And this paper may have some problem because there was also the prediction of the different size of the magnetic sphincter device, and they didn't do multivariate analysis. So it's not a great paper. We need certainly much more work, maybe multi-center, in order to, in this respect. And this is an interesting other paper where the authors wanted to complement MRS with solid bolus swallow in order to look at the contraction reserve with reference to anti-reflux surgery, to what happens after anti-reflux surgery. Because with the assumption that after a solid bolus swallow, the contraction reserve is triggered by higher resistance to outflow. It may be more pertinent to anti-reflux surgery. First of all, they found that the contraction reserve to solid bolus swallow was slightly less frequent than to MRS, both in healthy subjects and in patients with GERD. But what it is interesting is that concordance of the contraction reserve between the two stimuli was not complete. It was about in 60% of patients and healthy volunteers. And it became more important only in patients with ineffective motility. And what is interesting is that the post-ARS global symptom score in patients with hypermotility, in those who had no contraction reserve to both stimuli, was higher than those who had at least contraction reserve to one of the two stimuli. And unfortunately, in this paper, there was not a group of patients with severe late dysphagia because anti-reflux surgery was tailored to the pre-ARS manometry. But still, it's a very interesting topic to be able to use different stimuli in this respect and needs further study. Another point which is to me quite interesting is, can assessment of contraction reserve predict success of prokinetic treatment? We know that in reflux disease, prokinetic treatment has always been very, very disappointing. And Daniel Sifrin, quite a few years ago, showed that in patients with ineffective motility, if you give hydrophonium, in half of them, both the severe and the mild you can have effective waves. And it's suggestive that evaluation of contraction reserve could just pick up this part of the patients. And he did a study, and this was just an abstract in 2015 to DDW with azithromycin, and sorry, going up, yes, with azithromycin. It was a small number of patients, and azithromycin increased the DCI, but in a variable way in the various patients. And they showed that the contraction reserve could predict, with a sensitivity of 78 and specificity of 75%, this effectiveness. But this, again, was a small study. There are no more data in the literature. And again, I think this topic needs to be evaluated further. The solid test meal, certainly we know that in fact is able to show that a part of the patients with ineffective motility as standard HRM have a contraction reserve and they become normal. You see here that out of the 303, 126 had a contraction reserve during the standard meal, so they became normal. And this is, standard HRM and solid test meal in these patients. And another stimulus quite interesting is, again, increase in intra-abdominal pressure. And this is a stimulus which has been around for many, many years, and until from 1973 with Wiley Dodds. But the point is that, in fact, it could be a stimulus, again, driven by an increased esophageal emptying resistance. And this is a study of a few years ago with an abdominal belt with pressure cuff showing that in healthy subjects, DCI increased and also the length at the largest break decreased. But what it is interesting is just to see what happens with a very simple maneuver, the straight leg raise. And during single water swallows during this maneuver compared to single water swallows in the resting position. And this was done in 103 GERD patients. And you can see that both in the normal motility group, there is an important increase in DCI, and in the YEM group, the same. And also you can see that the number of peristaltic break decreased from 6 to 3.6, and the largest break from 4.8 centimeters to 3. So it's quite effective. And how does this compare to the contraction reserve after MRS? Again, unfortunately, the Macintosh cut this. But you can see here, well, it's not bad that there is something missing. The number of patients with an increase in DCI after LSR, you know, in 46, you've got to believe me, here is the MRS contraction reserve above, you know, is yes and yes, but there are 41 who have the contraction reserve after LSR, and they don't have it after MRS. And if you see the absolute value of DCI here tends to be higher after SLR than MRS. So they seem to work partly differently and complement one another. Again, interesting data to me to be studied in the future. And what about trying to avoid reflux testing in some of the patients? Now, can some of the provocative testing in future do this? Straight leg raise, again, seems to be quite interesting one. And I'll show you the last work, which is in international 13-center study, when this has been tested in patients with GERD-like typical symptoms. All of them had also pH testing, and we wanted to see whether the SLR test could predict the acid exposure time above 6%. And you can see here on the left, a patient with a competent EGJ where you have an increase in intragastric pressure, no increase in the esophageal one. And here you have an incompetent EGJ where the pressure goes up into the esophagus. And you can see that, in fact, looking at both absolute and percentage changes in peak esophageal pressure from the resting position to the SLR position made very good curve with a cutoff of delta increase, absolute increase of 11 millimeters of mercury being the best cutoff in order to separate those with pathological exposure from those with normal one. And also, a validation cohort has been studied into 146 patients. The analysis is in progress, and we've seen the results so far. And the area under the curve is brilliant again, and the validation cohort, 11 millimeters of mercury, is the important point able to separate the patients. And also, a score is being built using also some variables of EGJ function and YEM or not YEM. So we're going to see, I think, very interesting confirmatory result from this validation cohort. Now let's talk about provocative testing, maneuver in rumination, and related disorder. Related disorder is supragastric belching. Postprandial HRIM is the one. We know that the rumination and supragastric belching are frequently misdiagnosed behavioral disorders. We know also that supragastric belching is efficiently diagnosed at pH impedance, but rumination much less because there is no manometry during the test. And quite a few years ago, objective manometric criteria of rumination syndrome at postprandial high-resolution impedance manometry have been shown. And in this study, in 94 patients non-responsive to PPIs, postprandial CRIM showed that, in fact, in 20% there is rumination, and in some of them also supragastric belching, and 42% supragastric belching. At multivariate regression, the clinical data which is associated with rumination is the history of rumination, and at 24-hour pH and impedance, the variable is the number of weekly acidic reflux, which is associated both with rumination and supragastric belching. And the last paper I'm going to show to you is this pilot study looking at the accuracy of analysis of postprandial high-resolution manometry and impedance monitoring regarding rumination and supragastric belching. And this was done in 22 patients where both 24-hour pH and impedance monitoring was done and postprandial CRIM. And 3 experienced raters were involved, blinded analysis, and 2 of them are present here. And you can see that, in fact, individual rater accuracy of behavioral condition compared to the gold standard, which was clinical history plus evaluation of the 2 tests, was not very good, from 42% to 59%. And also the inter-rater agreement was quite poor. Rumination was more frequently identified during postprandial RIM compared to pH and impedance, and that's what we thought, whereas it was not the same for supragastric belching. I'm going to skip this consideration for the discussion and go to the conclusion. GERD, well, contraction reserve, we need more multi-center work to be done in order to evaluate the best stimulus, depending probably on the aim of the testing. Do we want to see, we want to evaluate whether a patient who has to have anti-reflux surgery is prone to develop dysphagia, or do we want to evaluate if a patient is going to respond to certain treatment? So might be different. Prediction of reflux. Well, SLR looks promising, possibly coupled with other high-resolution impedance manometry variable like EGJ variables. We heard about them before, peristaltic performance, baseline impedance during high-resolution impedance manometry. Rumination and related disorder. Postprandial CRIM may be useful in selected cases of suspect rumination, although rater accuracy into rater agreement is quite low, even among experts. So will automatic analysis be helpful? Will artificial intelligence help with it? And postprandial CRIM has negligible value in suspect supragastric belching, where 24-hour pH and impedance is an efficient tool. And I would like to finish by inviting all of you who have time to stay here some time to go to this exhibition at Museo del Paesaggio in Verbania, which is on the Lake Maggiore, 35 kilometers from Ascona. This is an exhibition of paintings of my grandfather, 52 paintings, and is going to be open until 25th of June. Thank you very much for your attention.
Thank you, Roberto. Nice data and nice painting. And we have time for 1 or 2 questions.
That was a wonderful synopsis. 2 quick questions, maybe a point. When you say an important increase in DCI, what do you mean by that? What's an important increase in DCI? First question.
Important increase, yes, probably was not very scientific. The point is that, in fact, generally, when you do these maneuvers, most of the subjects or most of the patients increase the DCI beyond the classical single water swallow, because these are felt to be stronger stimuli in different ways. And in fact, generally the esophagus, in many cases, especially the healthy one, responds by increasing DCI. And there is quite a high variability of this.
Yeah, so I would argue that an increase of 1,000 means nothing. I would argue that an increase in 2,000 means nothing. If it doesn't effectively move a bolus, and these ranges that we talk about and the scale of DCI really don't make it conducive to looking at it at this kind of model. And really what we should be looking at is peristaltic work and power. That's really what we should be looking at. The second question is, honestly, this has been going on since I was a trainee in 2000 with the first FIBI paper. We are chasing something for 22 years now, even after that paper, and still thinking that we are going to solve post-operative anti-reflux surgery dysphagia by looking at preoperative peristalsis. That's not going to happen, because the people who actually have significant dysphagia after an operation where they have food impactions and weight loss have an operative complication. It is not because of their preoperative motility.
Well, I don't know if you want me to jump in now or wait for my talk this afternoon.
Jump in now.
I agree with manometry is not going to be able to predict our way out of the dysphagia post-op, but it's not always a quote-unquote operative complication. We see significant dysphagia, when the surgery is gone as predicted. So I think there's more to the story.
When you say as predicted, is that in the context of a normal distensibility? When you look at this, a normal IRP, that these people are actually having significant dysphagia where they're having food impactions and weight loss? I mean, I think that's the distinction. I mean, people have dysphagia, but it's perception. And those patients can be easily treated with neuromodulators and hypnosis. The patients who come in with food impactions and weight loss post-operatively typically have a surgical issue that is not remedied by hypnosis or something like a neuromodulator.
I agree. Some of them are, but not all. I don't think we have the full story on post-op dysphagia. That's where we need the most help as surgeons.
25 years later studying this.
I would also push back on this, John. I think you're being far too broad brush about this. There are people with dysphagia who have, as a consequence of persistent ineffective motility, and the aim that we're trying to go here, trying to identify people who can respond to the additional barrier that is created by our surgeon friends, that is surely a valid thing. And I know you don't like ineffective and effective, but when one can assess, one shouldn't be focused purely on DCI. I do agree with this, but an effective swallow, we can define an effective swallow in terms that are a bit better than just DCI, looking at coordination, looking at breaks and everything together. It's an integrative function.
Well, I argue that manometry alone as a test is not going to work, and it has not worked for 25 years.
Watch this space.
Okay.
I agree with John.
All right, it's going to happen today.
Wait.
Behind you. Thank you, Roberto. Lovely talk. And I think there's going to be more debate on the topic we've just discussed. The single leg raise. Can we explore that that's actually testing the attachment of the phrenoesophageal ligament and the crural diaphragm to protecting the transfer of pressure? So are we actually able to measure that effectiveness of supporting the lower sphincter by doing that single leg raise? Is that telling us more than, when we're measuring just purely in the lumen of the esophagus relaxation and contraction? We're really looking at the external slightly and the combination of the lower sphincter and the crural diaphragm. But is the single leg raise giving us that additional information about how healthy or unhealthy the crural diaphragm effect is?
Well, yes, I think it's quite an interesting question, because I don't know whether we can answer at the moment. certainly the mechanism by which it works or not. It's interesting to know that it's not only the patients with dissociation between the LES and crural diaphragm where the legs raise is positive. It's also part of the patient with type 1 esophago-gastric junction. And it's quite interesting, and this is also what a previous study of 2 years previously had shown, especially that you are able to differentiate in between this group, which is generally considered the competent esophago-gastric junction, that part of them have an increased acid exposure, and these have this positive leg raise, positive increase in this esophageal. So probably you're right, but I mean, it's could be a possible reading. Yes, yes. So, absolutely.
All right, well, I think we're going to move on in the sake of time here. Thank you, Roberto.
Thank you.
Very nice. We'll welcome back Peter Kahrilas to the stage, who needs no introduction. If you don't know who he is, you may be in the wrong meeting.
You gonna help me out here, Mark? There's a nude picture here.
You're just not a man of culture, obviously. There we are. That's right, not in Florida anymore anyway, guys.
So we're going to cool this off a little bit and go back to talking about motility. This is pharmacological provocation testing during HRM in motility disorders. So we're going back to yesterday. I'm Peter Kahrilas, and my only disclosure is that I am not Arash Babai. So let's talk about the Chicago classification and basically pressure topography in general. And it's just a scheme for analyzing pressure topography plots. And the big innovation really was in developing these three metrics. The integrated relaxation pressure, which looks at that box at the bottom there and picks out the period of maximal relaxation over a 4-second interval of time. The latency is when that contraction arrives at the bottom. And the DCI, so vigorously debated just now, is the vigor of the contraction in the middle, measured in those curious units of pressure times time times length. And that all boils down to giving us this, which is the current version of the Chicago classification. And I'm going to focus just on specific elements of this. So if you have an abnormal IRP, and that has various definitions, and complete peristaltic failure, you slot into one of the three types of achalasia. So it becomes very important. If you don't have an abnormal IRP, you get a second chance. You change the position, and you see if you get an abnormal IRP that way, and then you can still get into the achalasia slot. But if you don't, you have 100% failed swallows. You then have absent contractility. So in trying to distinguish these two entities, achalasia 1 versus absent contractility, you're depending entirely on the LES function. And the IRP cutoff can lead you astray. You can have type 1 achalasia with a very low IRP, or you can have absent contractility with a high IRP. And that's kind of the fundamental nature of what I'm discussing here today, is how we get some help in that domain. So let's talk about the agents used. First, cholecystokinin. This is a peptide found throughout the GI tract and the nervous system. There are two receptor types, A and B. CCK-A agonists increase transient LES relaxation frequency. And a transient LES relaxation is a complex reflex. It amounts to LES relaxation, crural diaphragm inhibition, esophageal longitudinal muscle contraction, plus or minus a circular muscle after contraction. CCK-B receptors are located on the LES smooth muscle and cause LES contraction. Hence, CCK administration has the potential to induce LES relaxation, LES contraction, longitudinal muscle contraction,
or circular muscle contraction. So both excitatory and inhibitory myenteric plexus neurons can be stimulated by CCK. But it usually induces LES relaxation. And that comes back to this, which was the first description of this by my mentor, Jerry Dodds, in 1982. And he, on a small group of achalasics and normals, made the observation that when you administered intravenous cholecystokinin, the LES pressure went up in the achalasics and down in the normals. And on the right was his schematic there on how that might occur. And you see the CCK having a dominant effect on the inhibitory neuron in the normal subject, but in the achalasic subject who doesn't have that neuron or doesn't have the effectiveness or the working neuron there, the only effect you see is the stimulatory effect on the smooth muscle. Skip ahead, and this is from Raj now and Ravi Mittal looking at all of this in high-resolution manometry. And you're looking at LES relaxation without crural diaphragm inhibition here. So if you look at the arrow on the left, that's where the CCK is administered. Then look at the period immediately afterwards, and you see that the intensity of the EGJ signal has diminished over that 48 plus or minus 16-second period. And then there's the offset after that. So this is the response seen in 7 out of 9 of the normals. But 2 out of the 9 actually showed the opposite response, which is what you see here, with the CCK administration on the left again, and in the period afterwards you see LES contraction. This is what one might have predicted if they had achalasia, although it actually gets more extreme for the achalasics. And then there's phase 2. Go further down in time from where the CCK is administered, and now you're looking at the phase 2 response where there's complete LES relaxation for a period of, it looks like, 15, 20 seconds over there. And this is the combination of both, the early response with the contraction and the later response with the relaxation. But if you look carefully at this relaxation, you see an after contraction, you see a lift. So you're basically looking at phase 2 being a transient LES relaxation. So you get the initial response, and then you get the later response. The later response is a TLASR. They did a dose-response curve here in the normal subjects, and the relaxation response was quite evident at low dose. It diminished somewhat at the higher doses. The phase 2 response really came out only at the higher doses, but was seen in every individual at the higher doses of 40 nanograms per kilogram. So this is the other aspect of the phase 2, and this is from the same paper, where they're looking at the M-mode high-frequency intraluminal ultrasound recording to demonstrate that what you're seeing at the end there is, in fact, longitudinal muscle contraction, again emphasizing that this is a transient LES relaxation you're seeing in the phase 2 response, and part of a transient LES relaxation is indeed longitudinal muscle contraction of the distal esophagus. And this is an endogenous example of that. This is a very funny story, actually, looking at these transient LES relaxations in achalasics. I remember as this unfolded, because of the tech who we have very wonderful manometry techs, and she walked up to me and she said, "Oh, that's just," I was looking at this, and what is that? And she said, "That's just a transient LES relaxation. That happens all the time when we sit people up, going from supine manometry to sitting up, because we started doing upright swallows." And I said, but that's an achalasic patient. And he said, "Yeah." So here you're looking at every aspect of a transient LES relaxation except LES relaxation. You have the lift, you have the after contraction, you have the whole thing. And that resulted in us doing this study comparing that exact stimulus in normal subjects versus people with achalasia. And you can see the difference. On the normal subject on the left, indeed, they have a TLASR as you know it. And on the right, you see what a TLASR looks like in an achalasic. That's a little side note for you. Now let's talk a little bit about amyl nitrite, which is the other stimulus. So amyl nitrite inhalation, it's an NO donor, produces a rapid relaxation of smooth muscle. When the amyl nitrite reduced relaxation is greater than deglutitive relaxation, it suggests that the deglutitive LAS relaxation is impaired. So this is how it's done. It's a little capsule. You crack it and stick it under the nose and inhale it 4 times. And the first 60 seconds after inhalation is the relaxation phase, and the subsequent 120 seconds is the recovery phase. So the duration of relaxation is measured from the 50% drop to the 50% recovery. And this parameter relaxation gain is defined as the difference between deglutitive IRP and the amyl nitrite induced IRP. So this was a study where Arash compared type 3 achalasic patients to opioid-induced contractility disorder patients. Now, this can be a difficult clinical distinction because they have similar abnormalities. But if you look at this, the first underlying thing is the rebound contraction, and there's a highly significant difference in the group of type 3 achalasics versus the opioid-induced. It's almost double. If you look at the esophageal DCI, again, in the same phase there, again, it's a highly significant difference. And if you look at the CCK phase 2 response, again, it's very different in terms of the IRP, in terms of the degree of shortening, and in the terms of the magnitude of the DCI. So there seems to be a fundamental difference being much greater in the type 3 achalasics than in the opioid-induced group. And the importance of identifying that is, of course, that you don't necessarily want to render an achalasia therapy to somebody who has opioid-induced esophageal dysfunction. Ideally, what you could get them to do is discontinue the opioids, rarely accomplished, but in this case, it was accomplished. And this is a demonstration of a before and a 1 year after with no intervention other than discontinuing the opioid, and the abnormalities go away. So here are a few examples of this: amyl nitrite and CCK response in type 3 achalasia versus OIED. And the top tracing, you're seeing that the rebound contraction is not seen in the opioid-induced group, whereas you do see it in the type 3 group. You see the exaggerated phase 2 response in the type 3 group in the middle panel now, but not in the opioid-induced group. And you see a complete TLASR in a small minority of the type 3 achalasia groups, and that still shows some abnormalities to it, by the way, but in every individual in the opioid-induced group. So you have a useful way here of discriminating between what is really type 3 achalasia and what is induced by opioid use. So back to this flow diagram here. Let's go a little further along. And we're heading towards the EGJ outflow obstruction conundrum here. So we have some peristaltic function, and we're trying to decide if this is real. And now in CC40, what we're doing is we're invoking other testing, TBE or FLIP, to try to decide what is achalasia type EGJ outflow obstruction. And if you don't get that confirmation, you decide it's not clinically relevant. So a conclusive diagnosis of EGJ outflow obstruction requires some confirmation. And the working group tasked with this came up with quite a series of recommendations here. I don't want to enumerate all of them, but clearly they thought a lot about it, and they emphasized this point, which I didn't hear mentioned yesterday, which was that a manometric diagnosis of EGJ outflow obstruction is supported by evidence of abnormal EGJ function following pharmacological provocation. So let's look at that a little bit. This is the amyl nitrite response in normal, achalasia 2, and EGJ outflow obstruction. You see the pre-inhalation on the left, the amyl nitrite relaxation in the middle, and the amyl nitrite recovery on the right. In the normal subjects, we already discussed that, but look at what you see in the type 2 achalasia. They have a very high IRP initially, pre-inhalation. With inhalation, it relaxes completely, and they get a rebound after contraction. So it looks quite different than the normal. And this is that concept of the relaxation gain, if you'll have it, on the bottom there, where you see that you have the swallow-induced relaxation only going down a little bit, but when you directly stimulate the smooth muscle with amyl nitrite, it goes deeper. So you get a gain in relaxation, whereas the normal subject on top, they're the same. And then in the after contraction part, the normal subject, they're the same, whereas the achalasic below, you get that big rebound contraction. The etiology of which, by the way, is not known. So this becomes a useful discriminator to identify achalasia type EGJ outflow obstruction. And these are the two subgroups here. You have amyl nitrite responsive outflow obstruction on the top and amyl nitrite unresponsive on the bottom. On the top looks like normal, they relaxed. And then on the bottom, it really didn't change very much. And the explanations for why it wouldn't change are basically that there's some artifact of some sort that is giving you that signal of EGJ outflow obstruction initially. And these are the summary data from that study. Looking at the left panel over there where you have the normal motility group and achalasia type 2 patients, you see this linear relationship between relaxation gain and the deglutative IRP. The higher the deglutative IRP, the more the relaxation gain in both groups. So both of those are strongly correlated. But on the right panel, where you're looking at the amyl nitrite responsive in red versus the amyl nitrite unresponsive in green, it doesn't look that way at all. The responsive ones, yes, they've got that same linear relationship, but the unresponsive ones, basically, it's a horizontal line. So you don't get any relaxation gain. So conclusions regarding this outflow obstruction population. Well, in that study, and it was a fairly large group of people they had, 1 in 8 patients undergoing HRM had isolated elevated IRP supine. That's a lot. In 2/3 of these, there was no elevated IBP, and the high IRP resolved in the sitting posture. So that's, I think, an important aspect of CC4O is that you change the posture. Nearly 1/3 of the remainder were likely the result of chronic opioid use. So we're going to hear more about that from Marcelo coming up, but clearly this is something that should be elicited in the history. In 1/3 of the remainder, there was an amyl nitrite response similar to that seen in type 2 achalasia. So overall, if you take that initial group and multiply it by 1/3, then by 2/3, then by 1/3, 7% of the initial cohort then had achalasia type EGJ outflow obstruction, emphasizing, I think, the importance of all of these steps, perhaps even including this provocative testing. Now, the other circumstance that I outlined earlier was this one. Between type 1 achalasia and absent contractility. So the top panel is absent contractility patients with a high IRP, actually both panels are, but normal amyl nitrite and CCK response. So there's a high IRP, but if you look at the pharmacological stimulations with amyl nitrite, it relaxes, and you don't get that big after contraction. With the CCK, it relaxes, it doesn't contract. So they're giving you the normal responses, strongly suggesting that these are not achalasia patients, even though they have high IRPs. Here, on the other hand, you have absent contractility patients with low IRP, suggesting that they don't have achalasia, but abnormal amyl nitrite and CCK responses. So left panel, yes, both IRPs are low. The lowest one there is 3. Middle panel, give the amyl nitrite, and you see a little bit of augmentation there and strong after contraction in both cases. With the CCK, you see a lot of augmentation in the first one, and you see that, that abnormal TLASR response in both of them. So in their summary data on this one, 34 patients with aperistalsis reviewed to determine the final diagnosis of type 1 versus absent contractility, IRP plus the rapid drink challenge compared to pharmacologic challenge with amyl nitrite and CCK. The standard criteria misclassified 4 absent contractility patients as achalasia and 5 achalasia patients as absent contractility, which was in nearly a quarter of the overall group. So I think this is actually very interesting data. And you know, when I was a fellow in Milwaukee, we did this routinely with perfused manometry, and they never stopped doing it. I left Milwaukee, but they never stopped doing it. And what Arash did was compiled all of these data, which they do as part of their routine manometric evaluations. And the situations where it is shown here, I think, to be somewhat useful, is differentiating type 1 achalasia from absent contractility, differentiating type 3 achalasia from the motility changes attributable to chronic opioid use, and identifying achalasia type EGJ outflow obstruction. Thank you.
Maybe we have time for one quick question. Yep. Hi, John.
So I'll ask this question again like I did yesterday. How many people in the room do these provocative tests with amyl nitrate and CCK?
Nitrite, John, nitrite.
I used to do it until it was not available anymore in Illinois.
Can we use GTN? Can we just use the same kind of product that people use?
It doesn't work as quick. It's not as reliable. We did that too. We used to use that. But I will tell you that most of this can be resolved with common sense, some solid test meal, and a good barium esophagram with a tablet. And the fact that nobody does this should suggest that maybe we need to stop talking about this as part of these algorithms. I mean, it's interesting physiology, but you know, in terms of putting it into a protocol that we're telling people they should use, it might be time to say, you know what? Someone who has a type 3 pattern and is on chronic opioids, it's probably opioid esophagus. And if we stop the opioids, it'll probably get better. Someone who's absent peristalsis, who's got a barium column up to their clavicles, probably has real obstruction and achalasia. I mean, these are common sense issues. This is Occam's razor. I mean, we do not need to use these provocative tests in a routine protocol, even at a tertiary care center. So defend that, Peter.
I'm in a somewhat awkward position.
I agree with all of that.
Well said.
I still think it was a
well said,
fantastic
Peter.
talk. Thank you.
Yeah. All right.
And now the last speaker is Marcelo Vela from Scottsdale, and the talk will be opioid-induced esophageal dysfunction. Thanks for coming, Marcelo.
Well, good morning, everyone. I am, of course, very honored to be here, but I should say also very happy to be among colleagues and friends in person. It's really wonderful to see everyone again. So I've been asked to speak about opioid-induced esophageal dysfunction, which is obviously increasingly recognized. You've heard it, in the past couple of days as an issue that we need to keep an eye on. These are my disclosures, and what I'd like to do is very, very briefly remind you about the opioid epidemic that we're having in the US, and I think this is a problem in Europe and other parts of the world as well. Talk about the effects of opioids in the esophagus, and there are a lot of knowledge gaps there, but we'll go over the little we know, and then talk about this entity of opioid-induced esophageal dysfunction, how we define it, how it presents clinically, what the manometric features are, and how we go about evaluation and management. So this is somewhat older data, but over 10% of US adults have a chronic pain syndrome, and long-term opioids are prescribed to 3 to 4% of the US population. Just think about numbers, that's a lot of people. And this sadly has resulted in more than 160,000 deaths from overdose in the 1999 to 2014 time period. And there are close to 2 million folks abusing or dependent upon prescription opioids. This was 10 years ago. It's only worse now. So there's a lot of opioids in the US. In terms of what leads to opioid-induced dysfunction, it's obviously quite more complex, but in very broad terms, it appears that opioids interfere with inhibitory signaling in the esophagus. And so when everything is normal, this good balance between excitation and inhibition by acetylcholine and nitrous oxide, that organized balance leads to a good propulsive sequential contraction and proper relaxation of the LES. If you knock out the inhibitory signaling, which is what opioids appear to do, then you'll have impaired LES relaxation, reduced distal latency with premature contractions and hypercontractility in the esophageal body. And those are the types of things that we see in some of these patients taking opioids. So this term OID, we have used it to define patients that have symptoms of esophageal dysfunction, mainly dysphagia, but others, in the context of ongoing documented chronic opioid use with manometric abnormalities that are consistent with this, and those are abnormalities that would indicate impaired inhibitory signaling in the esophagus. The symptom presentation, this is based on the 3 sort of largest, more recent retrospective series that are available. About 60% of the patients have dysphagia. That's kind of the main issue. Chest pain in about 10%, and then GERD symptoms, which I'm not sure what that is, but in about 20% of the patients. So mainly dysphagia. Now, these are the findings this was one of our first reports using high-resolution manometry, looking at 121 consecutive opioid users presenting to our lab compared to, the 100 non-users. And indeed, we found higher rates of these disorders of impaired inhibition, achalasia type 3, EGJ outflow obstruction, distal esophageal spasm, and hypercontractile esophagus. Now, let me show you the numbers for what we found when we looked at the effect of opioid type and dose. This was a bit of a larger study. Again, all retrospective, but 225 patients that underwent manometry and were on opioids, and then 1,700 controls not on opioids. When we looked at those 2 groups, the patients on opioids had abnormalities in HRM consistent with OID in 24% of that population, as opposed to 9% of those not on opioids. And what we found most frequently in those patients taking opioids with an OID type HRM presentation was a lot of spasm and outflow obstruction, some jackhammer esophagus, and some achalasia type 3. Now, the likelihood of having these manometric abnormalities was somewhat dependent on the opioid type and the opioid dose. As you can see, the percentages of patients on opioids that had an OID presentation was higher for stronger opiates like oxycodone and hydrocodone as compared to the weaker opioid tramadol. We also converted everything to 24-hour morphine equivalent doses and found that in those patients on opioids that had the OID presentation, the mean morphine equivalent dose appeared to be higher. This was not quite significant. It may have been an issue of power. This has been shown in other studies too, that there appears to be a dose effect where you'll find these abnormalities more likely if the doses are higher. Now, more recently, Dan Patel and Mike Vasey have presented the largest study available to date, again, retrospective, but they looked at many years' worth of data and found 869 patients that underwent manometry while on opiates and compared it to over 4,000 patients. And indeed, they found that those on opioids had a higher rate of dysphagia as a symptom and also higher rates of hypercontractile esophagus and distal esophageal spasm, esophageal body abnormalities, if you will. However, there was no increase for opioid users as compared to non-users in the rates of EGJ outflow obstruction or achalasia. So they didn't see a true increase in impaired LES relaxation. However, I think this may be, and this may be my own bias, but it may be a dose effect because the median opioid dose for their population was 35, and we seem to see this more once you reach 45, 60, equivalents, morphine equivalents, which is like opioids better in Arizona than Nashville, I guess. Now, everything I presented to you is this retrospective data. Patients show up to the lab. Are you taking an opioid? How much? Yes, no. But recently, the Belgium group actually showed the effects of acute codeine administration. Small study, but very well done and very interesting in 9 healthy volunteers that had high-resolution manometry twice. The order was randomly assigned, but on one of the studies, they had intragastric infusion of codeine, and in the other one, they had intragastric infusion of placebo. And through various measurements, they found that while the patients were on opioids, the IRP was higher. So it appeared to interfere acutely on EGJ relaxation. 60 milligrams of codeine is a pretty good dose, too, I would say. And when they looked at the esophageal body, the distal latency was reduced when the patients were on opioids as compared to placebo. And indeed, 4 out of these 9 healthy controls would have met criteria for EGJ outflow obstruction while they were on codeine, but not while on placebo. Now, with this idea of documenting impaired inhibitory signaling, we decided to look at the response to multiple rapid swallows. You've heard about about this today. This is a single swallow. These are the multiple rapid swallows. And the normal response is complete deglutative inhibition during the multiple rapid swallow sequence, something that was described by Daniel Siffring a long time ago. Now, a lot of what you heard earlier today was about what happens right after the sequence, and is there augmentation? Do you have a good contraction reserve? But you can use this also to look at whether there's impaired inhibition, and when that is the case, you'll see that there are contractions happening during the multiple rapid swallow sequence, suggesting that the inhibitory pathways are not working properly. And so we looked at the response to multiple rapid swallows in 200 consecutive patients that presented to the lab with esophageal symptoms, the last 100 that were on opioids versus the last 100 that were not on opioids. We also had 20 healthy controls through a collaboration with our Mexican colleagues in Mexico City. Of course, everybody had manometry with multiple rapid swallows. And indeed, we found that impaired inhibition during the multiple rapid swallow sequence was much more frequent in those on opioids, over 50% of them. About 10% of the non-opioid users, and actually none of the healthy controls. Those 20 healthy controls, all of them had proper deglutative inhibition during the multiple rapid swallow sequence, suggesting that opioids do appear to interfere with inhibitory signals in the esophagus. So in terms of the evaluation, for us to say that somebody has OID that requires the presence of esophageal symptoms, in the context of chronic opioid use with the manometric abnormalities that are consistent with this problem, as to whether you should perform the manometry off versus on opioids. If they're on a short course, for instance, after orthopedic surgery or whatnot, then we want them to wait and just come back to the lab later on once they're fully off. But for those on chronic opioids, if it appears unlikely that they'll discontinue them because they have a chronic pain syndrome, and this is most often the case, if they are going to be on opioids for the foreseeable future, we actually perform the study on opioids because that's their daily, state of their esophagus. They're going to be on opioids. Of course, these abnormalities, type 3 achalasia, outflow obstruction, spasm, hypercontractile esophagus, they often occur in the absence of opioid use. So how do we distinguish between, true OID from idiopathic, abnormality in somebody who happens to be taking opioids anyways? Opioid cessation with repeat manometry is the ideal, but not very often possible. You heard from Peter, you can do things like, amyl nitrate challenge, which maybe can enable a distinction between idiopathic from opioid-induced, but not very widely available, not commonly done, and not sure that's going to be the answer. Finally, what to do with these patients? There's really no data. There are no studies, but it makes sense that opioid cessation, is the first thing you want to think about. There are a handful of case reports. I'll just show you one here where somebody with EGJ outflow obstruction, after they stopped the opioids, the symptoms resolved, the manometry, normalized, and there's a handful of reports, but really no studies. Part of it is very difficult to get the patients to stop. We're doing it now in a collaboration with our pain clinic and their opioid cessation program, which is a structured, several-day program where the likelihood of success is higher. And hopefully I'll report on that in the next, couple of years. It's going to take a while. It's attractive to think about using opioid antagonists. We use them all the time in opioid-induced constipation with success. So there are a few reports. For instance, this case of 3 patients that had a presentation consistent with OID. They also had constipation, thus justifying the use of naloxone. They put the patients on this medicine, and the dysphagia improved in all of them, but the manometry normalized in only one of them. So we don't know what this means. We don't know whether the changes in the colon are equivalent to what we see in the esophagus. It's something that also needs to be studied. As I said, there's really nothing. And finally, some of these patients, or maybe many of these patients, they're going to be on the opioids. You don't know if it's for sure opioid-induced or not, but they have type 3 achalasia or confirmed outflow obstruction. You're going to have to use conventional LES disruptive therapies. And so how do these patients do the opioid-induced abnormalities if you use LES disruptive therapies? This is, again, we have very little data, but this is from our partners at Mayo in Minnesota, Karthik Ravi and his group. A while back, they looked at 53 achalasia patients. 14 of them, about a quarter of them, were taking opioids. 70%, most of them had Heller myotomy. The rest had either POEM or pneumatic or some Botox. But when they looked at symptom response, at a very short follow-up, just 2 months later, the patients that were not on opioids did much better. Their response rate was 97% as compared to 78% for those on opioids, suggesting that maybe those on opioids don't do as well. Now, more recently, a different group reported their experience using POEM for patients with these manometric abnormalities. 89 patients, 20% of them were on opioids, and it was a mixture, mainly EGJ outflow obstruction, some hypercontractile esophagus, a little bit of achalasia 3, and some spasm. At 6 months, they did careful documentation of symptom response through the Eckert score, manometer with IRP, endoflip with EGJ, the sensibility index. And the patients looked the same, whether they were on opioids or not. The success rates were the same for POEM, whether they were on opioids or not. On subsequent, analysis, they found that there was perhaps a dose effect. At the higher doses, the response weren't as good. But the numbers get smaller, and it's hard to find statistical significance there. So again, in terms of management, there's really all the work to do. So to conclude, and in summary, opioids appear to interfere with inhibitory signaling in the esophagus, leading to manometric abnormalities and clinical presentations of achalasia type 3, EGJ outflow obstruction, spasm, and jackhammer or hypercontractile esophagus. It's very important to document opioid use in every patient undergoing manometry. If it's a short course, you just wait, do it later. But if they're sort of married to the opioids, chronically, then I would say just go ahead and test them because that's what their esophagus is like every day. There appears to be a dose-dependent effect with a higher likelihood of this problem with the stronger opioids and higher morphine equivalent doses. And in terms of managing this, there are no clinical trials to guide what we do. The common sense options include opioid cessation, probably through a structured program is the only way to go if you're going to pursue that. But you can think about decreasing the opioid dose or changing to something like tramadol because there's data to support that the problem may improve. Whether opioid antagonists such as the ones used for opioid-induced constipation may work is not known and also deserves to be studied. And at the end of the day, you're going to have to treat a bunch of these folks in the same way you treat primary or idiopathic abnormalities with LES disruptive therapies or other types of treatments. Thank you very much.
Thank you, Marcelo. We are a bit on delay, just 5 minutes. Okay. We have time for a couple of questions.
I was trying to run away.
Trying to escape.
Thank you, Marcelo. Fantastic talk, Rami Swayze from London. In the UK, we have opiate enjoyment, as we say. The patients who have had chronic use of opiates over the years, I find that those who then eventually have their motility tested after stopping opiates don't resolve. It's almost as though they neuromodulated over time, such that they've lost their inhibition, regardless of whether they've stopped the opiates. And I find that stopping the opiates in advance of the test for a brief period is probably not going to help, especially if the patients have been on years and years of opiate use. I'd be really interested in your study that you're conducting now to see if there is not only a dose response but a length of use response with regards to how patients respond after with motility testing.
Yeah, and we don't know how long it takes for things to resolve or how fully they resolve. We do know that if patients have the manometry more than 24 hours after their last opioid dose, the likelihood of finding these abnormalities is lower, but it's still higher than patients that are not on opioids, so we don't know how long it takes.
So Roberto did a study probably, 25 years ago, looking at morphine and showed the similar results that they saw in the coding study. So, kind of history repeats itself. I think a lot of the changes that you do see, though, and I keep harping on this, but these numbers, right? Going from an IRP of 10 to 15, going from a DCI of, 2,000 to 5,500. Like, what does that really mean? Going from a distal latency of 5.6 to 4.3. So I think in a lot of these patients, there needs to be further study, once again, with a good esophagram, tablet, documenting abnormalities before we start jumping into this, because we're seeing a lot of these patients being sent for POEM, and they have very minimal, abnormalities that probably don't have physiologic consequences. So when you actually looked at your data, did you see absolute magnitudes? Did you see people going from a distal latency of 6.5 to 3, or were these people who went from 5.5 to 4.2? Or did they just show up at like 4.4?
So we don't have acute data. Our data is all chronic users who present because they have symptoms. And not to digress much, but for instance, our EGJ outflow obstruction patients on opioids also have, we call them OID because they have abnormal barium emptying, they have symptoms, so on and so forth. So it's not just for everybody. But in terms of the acute changes, I think it was the Belgian group that did that, and I think there was a very stark decrease in distal latency and an increase in IRP on the acute administration.
Yeah, because barium emptying can be quite normal, even to a distal latency of 3.5 seconds. So it's just, I think sometimes, we focus on these numbers, and the numbers shouldn't define the disease state. It should be the entire clinical picture, so.
Yeah, I'm in the business of protecting my patients from interventions that they don't need, so we look at these things very carefully. Doesn't always work. Somebody find a POEM somewhere else, but. Right.
Is there another question? She's coming.
Hi, Nir from Tel Aviv. Thank you. That's a great talk. Just for, I know there's no data, but what do people do? How long do you wait before you repeat manometry, or you think this is it and EGJ-directed therapy is indicated? Like, how long do you wait and give it a try if they manage to stop?
So we don't know, and we've just sort of made this up. And so for patients that we actually are trying to wait 4 weeks. I think after 24 hours you may see some cases. For our study, we ended up having to agree on 7 days because some of the patients coming for this sort of treatment are from out of town, and so it's hard to keep them around. But these are made up numbers. God spoke to me in a dream and said 4 weeks. Yeah.
Wow.
Yeah.
Impressive.
Yeah.
God's given you some good ideas.
Hi, Jenny Myers, Adelaide. Just want to ask you a quick question regarding, like, we see cells where we can, and I always ask them when they come in 2 days later after ceasing how their dysphagia is, and I'm really impressed with when they say, "Oh, it's so much better now."
You mean
I
after
haven't done the manometry yet?
After discontinuing the
Yeah.
So what I can tell you is that the burden of dysphagia for those on opioids appears to be very high compared to those not on opioids, even for the same, or higher, even for the same manometric abnormality. Whether, what it does to sensory pathways, we don't know at all. So.
All right, I think we're going to close the session and get on to the coffee break. Thanks, everybody. Thanks, Marcelo.